Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Omni Family Health for anchoring today's session, Diabetes Management in the Primary Care Setting with Doctors Cynthia.Leigh, Sushma Reddy, and Craig Sadur. I'm just quickly going to bring up our disclosure slides so you can see that, and then I will turn it right over to here. And you don't need to put your name into the chat unless somebody is using your computer. So if you are logged in, you'll get credit for this. So here's our disclosure slide and our accreditation slide. And with that, over to you guys.
Okay. And okay. Thank you so much, Kristen, and welcome to everyone. Good afternoon. And today, we were going to talk about diabetes management in the primary care setting, a field that has evolved and changed quite a bit over the years. So today's objectives are to recognize which diabetes medications are optimal for patients who present with different circumstances, and to apply the current technology that has changed so much for glucose monitoring, and to demonstrate different approaches for managing patients who have diabetes. So the agenda is to start with the overview, to go over medications, to dive into glucose monitoring, to review patient-facing technologies, go over some patient examples, discuss the technique of patient negotiation, and to finish it with a list of resources. So with medications for type 1 diabetes, insulin, of course, and classically, it's been a basal insulin to give that 24-hour coverage, and bolus to help cover the spikes that occur with meals. And the insulin pump, which gives continuous subcutaneous insulin infusion, has evolved quite a bit over the years. With type 2 diabetes, it used to be pretty much metformin, sulfonylurea, insulin, we're done. Now the medicines are based on many nuances, particularly comorbidities, weight issues, A1C lowering, hypoglycemia risks, cost of the medications, and if there's symptomatology. And if possible, a preference for simple medication regimens such as the once-weekly GLP-1 receptor agonists. This is a very busy slide that, of course, we wouldn't expect you to look at carefully during this talk, but as Kristen said, you will be getting the slide set, so you'll have it. And just a couple of things to mention with this. It comes from the American Diabetes Association, which comes out once a year in January with their standards of care. And this is listed as 2025. It's sort of like Back to the Future, even though we're still in 2024, but they did publish it this month. And to direct you, we've got in the column on the left, we have the different medications. And these start with metformin, the SGLT2 inhibitors, the GLP-1 receptor agonists, et cetera, and including insulin. So you've got the different options right there. And with that, we've got the different properties of the medications, things like how effective they are at lowering glucose. What is the risk of hypoglycemia, weight issues, cardiovascular benefits, renal benefits, cost issues. So you'll have it as a reference that I have found very helpful. So it used to be pretty much, okay, you have diabetes, you got high sugar, we better get the sugar down. That's still important. But what's happened over these last number of years is that people have been looking far beyond the glycemic control and really going to that sooner rather than later. We've got the SGLT2 inhibitors that have been beneficial for patients who either have or have, excuse me, who either have or have high risk for atherosclerotic cardiovascular disease. They're particularly helpful with patients who have heart failure, chronic kidney disease, and they help with weight loss. We've got the GLP-1 receptor agonists that similarly are beneficial for patients who have or who are at risk for atherosclerotic cardiovascular disease, chronic kidney disease, and they're very helpful with weight loss. We've got the thiazolidinediones like pioglitazone that are helpful with what used to be called non-alcoholic fatty liver disease, and has been changed to the tongue twister metabolic dysfunction associated steatotic liver disease, 20 syllables, which is more descriptive, but is a challenge. But it is truly an important comorbidity for patients who have diabetes. And this is the drug classification that has shown benefit. It also is relatively inexpensive. And what's been new in the last couple of years with the publication from the American Diabetes Association is the field of heart failure. And consider screening adults who have diabetes with either a BNP or an NT-proBNP to try and prevent them from having stage C heart failure. So if you have an asymptomatic patient, you do one of these tests and it's abnormal, then it's recommended to check an echocardiogram because you could identify a patient who could be at stage B heart failure. So it's finding out sooner rather than later. And the benefit is we've got the medicines now. The SGLT2 inhibitors have been shown to be effective for patients with heart failure. So this is the second, and from my standpoint, the last busy slide that I'll give you, which again is from the standards of care for diabetes. And it gives you a pathway in how you can individualize care for your patient. And it starts out with the healthy lifestyle, which is always the cornerstone of therapy. Patients with type 2 diabetes frequently, maybe perhaps 80% in some studies, are overweight, if not frankly obese. So if patients can improve lifestyle, if they benefit with improved nutrition, if possible, some weight loss. And there's also the self-management concept. The more patients know about their diabetes, the better. Monitoring is so important, and Dr. Reddy will go into that in great detail. And the social determinants of health, which you folks see every day in your clinic. These are factors like economic status, educational status, environment, other factors of health literacy. So these are things that even before the patient makes it to the clinic, goes to the pharmacy, are important determinants of how well that patient could do with their health, and in particular diabetes. And this is a reminder from the American Diabetes Association to avoid therapeutic inertia, which all of us clinicians and patients can fall into just by keeping the same thing going on indefinitely, but rather to reassess and to modify treatment regularly. If not every 3 months, at least every 6 months. Is this patient on the right track, or should there be changes? And after that, then you're starting to go, okay, which medication prescription would be beneficial for a patient? So what's new in the last few years is to think complications first. So these are the cardiovascular and renal concepts, where if the patient either has the disease or is at high risk for it, if so, you can go down a pathway and individualize care so you can have a specific treatment. And now with increased awareness, which has now made this chart for the first time, is the metabolic dysfunction associated steatotic liver disease. It is now rising in awareness. It will soon, they think, be the #1 cause for requiring hepatic transplantation. And patients with type 2 diabetes, particularly if they're obese, particularly if they're hypertensive, and have dyslipidemia, are at high risk for it. And so there are patients who are running around who have it, don't know it, and it'd be important because there are treatments. So after you've looked at complications, and if the patient still doesn't have enough glycemic control, then you can add on, if need be, for that. And you can be looking specifically at glycemic goals and what to add on, as well as weight management, which often can be a dual benefit for patients. Regarding glycemic control, obviously insulin is the most effective for bringing sugars down. But to give you a thumbnail sketch of patients who are candidates for medications that are not insulin, the ones that do the best at lowering A1C are the new kid on the block, the GIP-GLP-1 receptor agonist combination, 2.3%. And the GLP-1 receptor agonist, almost 2%. So those are the best. And the ones that are almost as good, sulfonylurea, biguanide, that's metformin, the SGLT2 inhibitors, thiazolidine, that's pioglitazone, roughly 1%. So if you have a patient who's a little, let's say has A1C of 8%, you're trying to get it down to 7%, these may be all you need. But insulin is always in the background as the most effective. GLP-1 receptor agonists and SGLT2 inhibitor considerations, things to keep in mind if you're going to add these. So if you're going to add one of these drugs and the A1C is at or near target, but you're giving it because of cardiorenal concerns, or if the patients had hypoglycemia issues, when you add one of these medicines, and if a patient's on sulfonylurea, probably best to stop it. And if the patient's on insulin, consider decreasing that dose and, of course, monitoring. If you add the SGLT2 inhibitor and a patient's on a diuretic or other antihypertensive med, while the blood pressure, let's say, is right where you want to target or close, or if there's volume issues, you may need to make some changes in the current regimen. And here's a picture of that. If you're going to add the SGLT2 inhibitor to a patient who's on diuretic therapy, you want to assess volume status. If they're hypervolemic, then you want to continue the diuretic, but monitor them closely. If their volume contracted, you want to stop the diuretic, replete their volume, and then start the SGLT2 inhibitor when they're euvolemic. If they're already euvolemic, you look at the blood pressure. If they're hypertensive, keep the diuretic going. If they're normotensive on thiazides, keep it going, but monitor the blood pressure. If they're on loop diuretics, consider decreasing that dose, but of course monitor. And if they're hypotensive, then you definitely, want to approach that first before adding on more drugs. If a patient's overwhelming issue is cost, and in terms of which medicine, Medicaid, Medicare, insurance formulary, local pharmacy, drug companies have had medicine options that can be used. A lot of times there may be, let's say, only one SGLT2 inhibitor drug, but that's the one that's available, or maybe only one GLP-1 receptor agonist. More and more there's availability. Thiazolidine like pioglitazone, inexpensive, and as mentioned, it's a good candidate for the metabolic dysfunction associated steatotic liver disease. But if you have a patient who's edematous and or with bone fracture risk or bladder cancer, probably not the best choice for that patient. Go somewhere else. Sulfonylurea, if you're going to give it, it'd be best to give one of the newer ones like glipizide, but watch for weight gain, watch for hypoglycemia. Insulin, also very inexpensive if you use NPH regular, but watch for weight gain, watch for hypoglycemia. And preemptively, again, if patients can do lifestyle, if they get their nutrition improved, if they lose some weight, if they exercise, and as Dr. Reddy will show you the continuous glucose monitor readout, these can be things even before adding on meds that have been beneficial. Just to give you a plug, the Endocrine Society has a mobile app for clinical practice guidelines. It's free of charge. You don't need to be in the Endocrine Society. You can put on your smartphone and look things up quickly. This is a pictorial on shooting for A1C targets. Sometimes we go, let's have really good control. If you want to have an A1C under 6.5, patient's doing well, has good resources and doesn't have overwhelming medical issues. And if you get most patients, you can shoot for under 7. As you age, maybe shoot for under 7.5. If you have complex medical comorbidities in the 7s, you'll be happy with. And if you have patients with poor life expectancy, let's say severe dementia, we don't even look at A1C because it's clinical judgment. And these give you some of the modifying factors when you go, let's tighten the control, shoot for A1C that's really good, or let's kind of ease up on the gas if these issues are at play. And with that, let me go ahead and stop sharing my screen, hand it over to my colleague, Dr. Reddy.
So another thing we all need to do is to monitor the glucose levels. And the way we've traditionally done that is using a blood glucose meter, where the patient, as you know, has to poke themselves. It just tells you what the glucose is at that point in time. Patients need to have adherence, so they should be doing it. And a lot of times patients will just check their glucose and not do anything about it. But we also have to make sure that the meters are accurate and that the patient is using the correct technique. Unfortunately, the blood glucose meters often do not meet accuracy standards. And this is actually a study that was done with the Diabetes Technology Society, where they looked at over 1,000 patients at 3 different clinical sites. And all these blood glucose measurements where they poked the patient's finger was done by a trained healthcare professional. And they used 18 of the most widely prescribed blood glucose meters. And look what they found. Only 1/3 of them met the accuracy standards. And these standards are over here. They're the International Organization for Standardization. So we need to make sure that our patients have accurate blood glucose meters. And here's a list of some of them. And then we need to make sure that they're doing the right finger stick technique. For example, if you were peeling a grape, although I don't know anybody who would peel a grape, but it gives you an idea here, and you didn't wash your finger, that glucose would be 360. And if you then washed your finger, it goes down to 93. In fact, I used to take care of a lot of patients with gestational diabetes, and I had one patient call me panic-stricken. She's like, Dr. Reddy, my glucose is 250. And so I said, wait, just calm down, wash your hand, I'll stay online, let's check your glucose again. And it was 90. What happened was it was winter time, and she had used a lotion on her finger that had some fruit in it, and so it was high. So we need to make sure that the patients are doing the proper finger stick technique. And if they can't wash their hands, ask them to use that second drop of blood so you're not getting the food contamination. So we know that with the blood glucose meter, you're poking your finger, you just know what it is at that point in time. And if you're lucky, you'll get a couple of readings from the patient if they remember to bring their logbook in and are actually checking. So is there another way? And yes, there is. As you've all probably heard, there's continuous glucose monitors, or CGM. We as endocrinologists love acronyms, so CGM for short is continuous glucose monitor. And here for this picture's purpose, we have the Abbott Freestyle on the arm. And there's a small little filament that sits under the skin that's measuring glucose levels in the interstitial fluid. And current CGMs can measure glucose every 1 to 5 minutes. So all of a sudden, instead of these 1 to 4 readings, you have a wealth of data up to over 1,000 readings a day. So you can tell what to do with this patient. So let's see what this means from a practical standpoint. Here's a patient, comes into your clinic. Here's 70, here's 180. They are actually checking their glucose, bringing these readings, and you're thinking, yay, you're doing a great job. What if this patient was wearing a CGM? Look what happens. Oops, here's where they were high, and here's where they were low. So you can see how that CGM can give you a much more complete glucose profile where you don't miss the highs and you don't miss the lows. And for the patient, it's real time. We already heard Dr. Sadur talk about how under the ADA standards, we look at healthy lifestyle, diabetes self-management. If your patient has a CGM, they can immediately see what happened when they ate maybe that dessert or maybe rice or cereal. And that will lead to immediate changes in lifestyle as well. So let's look at a couple examples. This is a 60-year-old patient that I saw in my office, type 2, on glimepiride, metformin, pioglitazone. Her A1C was 9, but she kept saying, Dr. Reddy, my fasting glucose is 120, and before dinner, sometimes I'm actually low. I get to 60. I, of course, didn't believe her. I said, your meter must not be right. How could you have an A1C of 9 and have hypoglycemia? I had her bring her meter in. Her meter was accurate. She was using a good one. We luckily at that time had access to a CGM where our clinic actually would buy the sensor and put it on the patient. This was over 15 years ago, by the way. And here's what we found. Let me walk you through this. Here is glucose levels, 180. So this is kind of 80 to 120. Here is time of day, 3 a.m., 6 a.m., 9 a.m., 12 noon. Each of these colors is 1 day. So when you look at it from midnight to 6 a.m., just like you said, she's around that 80 to 120 most of the time. Before dinner for these 3 days, like around 6, she was in the 80 to 90, sometimes a little higher. But look what happened after breakfast. She spiked all the way to 400. And when I talked with her, she said, Dr. Reddy, I'm eating a cereal and it's supposed to be a good cereal. And we know from working with gestational diabetes in my practice, anecdotally, I found that about 25% of patients would have a high glucose with cereal. But just think, if without the CGM, I would have no clue that she had this spike after this meal because I'd have just been checking before breakfast, before dinner, unless she was doing a number of checks for us. And this led to us changing her management. We actually added a small dose of insulin and her A1C stayed between 7 to 7.5. Here's another patient. I'm sure all of you have these in your clinics, 50 years old, type 2. He's on metformin and he was on basal bolus, glargine and aspart, and his A1C is 10. And you know, they come in and they go, I'll follow, I'll do what I need to. They come back in 3 months and the A1C is still in 9 or 10. You know, they're really not maybe missing their insulin or watching their diet. You know, something's not right. So I showed this to the patient, and again, same thing here. Here's glucose, here's time of day. The green shaded area is 70 to 180. So I explained this the same way to the patient, and I just paused. Patients love visuals. He immediately said, Dr. Reddy, you know the spike over here? I went out with my grandkids, and I decided to have some ice cream, and I didn't have my insulin with me, so here's a spike. And the next day he'd gone out, and he had a big dessert at bedtime, so he decided to take a big dose of insulin because he wanted to look good. And he ended up too low. And so we walked through this whole thing. At the end of it, he says, Dr. Reddy, this thing's pretty helpful. Can I get one of those? And luckily for most insurances, Medicaid for type 1s for sure, some type 2s in some states, Medicare, covers CGM for patients who are on insulin. So we got him his own CGM and his A1C stayed between 7 to 7.5. Sometimes it drifted up to 8 when he was just not remembering to always take his insulin, but definitely improved his control. So let's look at the CGMs. There are a bunch of different ones on the market. The ones that are most commonly used are the Abbott Freestyle Libre and the Dexcom, and that's what I'm going to dive into. So when you look at the Abbott Freestyle Libre, the newest version is a Libre 3, which is available to all patients. Here's your little applicator with the built-in sensor. It's a little filament that sits under the skin. It's measuring glucose in the interstitial fluid. And this is a reader, or if the patient has a smartphone, they will see the same data on their app. So now they get to see the glucose, 112. They know where it's headed. They could look at the levels the last couple hours. So it's really helpful. They know where they are. They know where they're headed. And then we want to make sure they're accurate. So for CGMs, we use something called MARD that tells us how accurate a CGM is. And anything under 9 is good. And this one's 7.9. Each sensor is good for 14 days, and you typically wear it for the Libre on the arm. The cool thing about it too is that you can set alarms for low glucose as well as for high. And there's a factory preset that comes with a low glucose less than 55. So think of your patients on insulin or on a sulfonylurea. They would be warned of these glucose levels. For the first 12 hours, however, though, they should use a meter to make treatment decisions like giving insulin because it's not as accurate. And looking at the Dexcom, it's again very similar. You've got an app or something called a receiver if they don't have a smartphone. You've got the applicator with the sensor. The difference is the wear time is 10 days and the warm-up time is only 1 hour. Again, a good MARD, so it's accurate. You can set alarms and it could be worn on the buttock or abdomen as well. An extra feature it has is it can warn you 20 minutes ahead of time if you're going to be less than 55. So if I'm in a meeting and I'm going to drop low, I'll get a warning 20 minutes ahead of time. So how do we know that CGM helps? This is the first study that was a randomized trial of 158 patients with type 2. In brown is the usual care group, in green is the CGM group. And you can see that in the group that used CGM in all categories, there was a significant reduction in A1C compared to the usual care group. Here with the group with the baseline A1C of over 9, you see a 1.4% reduction in A1C versus 0.7. So this was the first study that showed us that CGM works in patients who are on multiple insulin injections, and you get better outcomes than using just a blood glucose meter. But here's the slide that I love the most. They looked at patients depending on whether they're good at counting numbers, their age, and here they considered 60-old, which my definition of old has kind of changed over the years. And they looked at education level. The important thing is it did not matter what your education level was, what your age was, whether you could count numbers, everyone benefited. And for me, this meant that every patient that walked into my office who was on multiple insulin injections would benefit from a CGM. So we talked about the impact of how the CGM tells you what, not only where you are, but where you're headed. Patients no longer have these sore fingers. I've had many people complain, electricians, musicians, that they can't poke because they can't do their job because their fingers are so sore. But they also get alerts, so it prevents low glucose. And it helps with changing behavior. I had a patient who underwent bariatric surgery and he put a CGM on. And he came back to me and said, Dr. Reddy, this thing doesn't lie. I'm like, what are you talking about? He goes, I ate an apple pie and my blood sugar went to 400. I then ate half and it went to 200. So I just threw the pie away. So think of how many times you've told patients what to do and they listen with one and it goes out the other ear. Put a CGM on. All of a sudden that invisible becomes visible and you'll see that change in behavior and lifestyle. If your patients are on insulin, they know exactly how much to give because they can see where they're headed. One of my patients who was on a sulfonylurea called it his GPS because he now knew where he was headed and he could go to bed without worrying about a low glucose. And there's been good studies done showing that in patients on multiple insulin injections, using a CGM prevents hospitalizations related to DKA and related to diabetes. So again, cost saving as well for the entire health system. So I wanted to share with you some data from when I worked at Carbon Diabetes Care. I want you to pay attention that our care model consisted of personalized team approach, which all of you do. We also added in a CGM, so patients could have that direct feedback, and we had that data set to see what to do. And we also addressed diabetes-related distress using something called PAID, or Problem Areas in Diabetes Assessment, which I'm happy to share with all of you. Through Kristen, we can email it to you. But here's what we found. Here you've got the A1C change, and here you've got the A1C categories. And no matter where they were, all patients improved. And look at this. If you had a baseline A1C of more than 9, the average A1C change we saw was a reduction, absolute, of 4.3%. That's how powerful this can be. And we got over half of patients to goal within 4 weeks. And 68% achieved an A1C of less than 7 at follow-up. So certainly use this as a tool in your armamentarium as you're looking at those individuals with uncontrolled diabetes. So how do you incorporate it into your clinic? My suggestion from a personal standpoint would to consider starting it on all patients, at least let them wear it once so you can see that lifestyle change. You can make the right adjustment in medication. And so the patient, you're probably saying, now, how do I do this in the clinic? I mean, we don't have time, patients don't have insurance. Well, Freestyle Libre Abbott has a program called My Freestyle where you can get 1 free sensor per lifetime, and they can wear that for 14 days. And if your clinic has some grant money, you can do a grant program through Abbott, and I'm happy to make that connection for you if your clinic is interested, where you'll be able to obtain sensors for $25 each that you can give to patients who have no insurance. If your clinic does have some Medicaid or Medicare patients, you could buy one of the professional CGMs. An example is the G6 Pro, where the cost of the sensor is only $59 and there is reimbursement for it. So then you have the patients do this as a science experiment. Try a big portion of food, small portion, go for a walk, try foods you think are good for you, try foods that are bad for you. And so now they've experimented and will start changing the behavior, and you get the data to make the right treatment adjustment. So when you see them back in a week, you can adjust it. If they are on insulin and have some kind of insurance coverage, they will qualify for a CGM. Patients who have hypoglycemia also qualify for a CGM for most insurances. So here's the My Freestyle program. One word of caution is you can't use it for Medicaid or Medicare patients, and it's only 1 per lifetime. Your patients do need to have a smartphone. If they don't, you could consider buying 1 reader for the clinic and then loan it out. And so in order to view the data, you could use the company's platform, such as LibreView for the Libre or Clarity for Dexcom, or their general platforms such as Tidepool or Gluco, where you can see all CGM's data. And you could also look into remote patient monitoring, where you're able to reach out to the patient in between visits and make adjustments rather than waiting for 3 months when they come back. And there is reimbursement for this as well. So here's some more information about Tidepool and how this platform is good for both patients and for clinicians. Here's some data on the reimbursement, and you can see that if the cost for a sensor for the office is $59 and you're inserting, Medicaid does pay for it, both the insertion and the interpretation, and there's codes for RPM or remote patient monitoring as well. And so you can see how we can now use the other technologies such as telehealth to help improve our patients' overall outcomes in between visits. Because diabetes is not, one day, it's 24/7. And we're seeing them only every 1 to 3 months. So they then can get support in between visits. And this is a listing of some of the apps that we have found helpful that you could pass on to your patients as well. And then you're thinking about, now, what do I do? I have this person in front of me, uncontrolled diabetes. I'm having lots of trouble. Where do I start? First recommendation is get a CGM. All of a sudden, the patient is seeing the data. The invisible is becoming visible. They start to make changes. And then you have a complete glucose data set to make the correct treatment for this patient. I know all of you address social determinants of health. That is a big barrier. In addition, there are diabetes-related distress, which can be a barrier, which can be improved with what you do in the clinic with your whole diabetes team. So I would suggest doing this assessment as well. And then you'll hear from Dr. Sadur later on about negotiating with the patient and kind of meeting them where they are. And with this, I'm going to turn it over to Dr. Leigh, who will talk about how you manage these patients with uncontrolled diabetes. Thank you.
For the next 12 slides, I'm going to switch from talking about all this fun high-tech stuff to some basic low-tech ways that we can identify and address barriers to achieving good diabetes control, both from the standpoint of our patients and from our standpoint as medical professionals. So this is a visual representation of the importance of nutrition and physical activity, lifestyle, in reaching good glucose control, followed by medications. No medication will work as well as it could or should unless it is picked up from the pharmacy and taken as prescribed on the foundation of a healthy lifestyle. And next slide. This is a sampling of patients from our diabetes clinic, and it documents the impact of diabetes education. As mentioned, diabetes is a self-managed disease, so the more our patients know and understand about their diabetes, the better they will do. DSMT, or diabetes self-management training, is a part of every diabetes guideline. So this data is routinely collected as part of our clinic's maintaining its ADA recognition for our diabetes team. The clinic policy is that all patients referred for diabetes will meet with the RN and RD CDEs, certified diabetes educators, first, and then will be scheduled to meet with the endocrinologist. So these are 5 patients with type 2 diabetes referred to our clinic. The middle column shows the hemoglobin A1C measured as the patient is checking in for their very first visit with the diabetes education team. So this is how they're coming to us. There is typically about a 3-month gap between the educator visits and the initial endocrinology consultation. The hemoglobin A1Cs in the third column were measured as the patient was checking in for their very first visit with the endocrinologist. The improvement in hemoglobin A1C that you see, therefore, is entirely due to changes made by the patients working with the education team. And it ranges from pretty good, a drop of 1.3%, to a nice jaw-dropping minus 4.7%. And if you were fortunate enough to add a CGM to that, you can see how powerful that would be. So if your clinic has not already done so, identifying a diabetes team close to which you can refer patients, as many as possible, and establish a relationship with will definitely benefit your clinic population. And next, from the patient side, this is a survey that I saw from Consumer Report. They surveyed 5,012 patients with type 2 diabetes. 75% at this time, this is a few years ago now, were overweight or obese at diagnosis. Their most important strategies that the patients identified for successfully managing their diabetes included improving their diet, losing weight, and increasing physical activity. It was also noted that the RN and RD CDEs were more helpful than the primary care providers or the endocrinologists in educating patients about nutrition. And the overall summary from the patient's perspective is that controlling their obesity was critical to successful management of their diabetes. Next. This is just a brief comment, brief slide on weight management separate from diabetes. They overlap a huge amount. But of course, it also includes behavioral therapy, foundation of treatment, again, being lifestyle interventions, and with diabetes. There are several medications out there right now. Of course, the GLP-1s are front and center. And then there's bariatric surgery. And there are several different procedures available. Ideally, you should have a multidisciplinary team that follow these patients long-term. But so far, bariatric surgery remains the most effective as far as percentage of weight loss and the duration of weight loss. And next, this is a patient who was in our weight management clinic, which we did with the bariatric program, and so these people were morbidly obese. This was a 55-year-old male who also happened to have type 2 diabetes, hemoglobin A1C 12.4% as he entered the program. And this is an example of what his blood sugars were using CGM for a couple of days before he was initiated on the diet plan that they started with. So as you can see, he's virtually never in goal range. And then the next slide is another set of home glucose readings taken, and this is all within the same week, taken once he has started the diet. And just to be a little more specific, this diet was not a full-on keto diet, but it allowed low carb. It was just called low carb intake, and it was 10 to 30 grams a day. So there's a dramatic improvement, and almost 100% of the time following this diet, he is in goal range. And his hemoglobin A1C that was predicted based on this to drop down to 6.5%, which is lovely. Let's see. Then the next couple of slides are looking at optimal diabetes care, the challenges that we all face as providers. And this was a survey of both primary care and specialists dealing with diabetes. As you can see, there's a couple of things that are in the top 3 for both groups. Insufficient time, I think that's probably universal, but patient adherence was also mentioned. And so for the rest of my time, we're going to address the difficulties we have on trying to improve our patients' abilities to succeed. So looking at the next slide, one of the things we can do is analyze what medications they're already on. Most of our patients not only are on multiple medications for diabetes, but they also have polypharmacy in general and are on a ton of medications for the other chronic diseases that we usually see in combination with diabetes. So when reviewing the medication list, look for opportunities for a medication makeover. So this first example is an old but cheap combination using metformin, 1000 BID, a sulfonylurea, 5 BID, and then 1 shot of basal insulin. So if you analyze this, you're showing a dosing of 3 times a day, breakfast, supper, bedtime. There are 2 routes of delivery. You've got 1 injection and some oral medication. Your total daily pill count is 4, and the timing is spread out through the day, breakfast, supper, and bedtime. So to start to streamline the medication or the regimen, you can change the metformin to extended release, and that can be taken once a day. Classically, it's with the largest meal, usually supper. You could swap out the sulfonylurea with either a GLP-1, which is 1 injection per week, or an SGLT2, 1 oral pill daily. And you can make this decision, see the charts that Dr. Sadur showed you earlier on which would be the best choice. You can move the basal insulin from bedtime to either breakfast or supper at the same time as they are also dealing with their diabetes in other ways. This reduces the timing of their diabetes medications from 3 times a day to twice a day, breakfast and supper. The routes of delivery remain the same. You still have an injection, or you may have an injection, and oral medications, but you reduce the timing down to twice a day. And if they are not yet on a CGM, that's typically those same times that they are also doing fingerstick glucose testing. So it simplifies their routine. And then our next 4 slides here are a real live case we had in our clinic. This lady was a 59-year-old female, had 14-year history of type 2 diabetes, initially started on metformin, which was standard at the time, and for a year did fairly well with hemoglobin A1Cs of 7-ish. And then a year later, things started to deteriorate, so glipizide and glargine were added. And then for about the next decade, she did not do as well. And so Humalog was added 3 times a day before each meal 1 year prior to the consultation in our clinic. At the time of her initial visit with the diabetes education team, her A1C was 10.4%. This was her medication routine: basal insulin, 25 units in the morning, 30 units at bedtime, Humalog, 5 units before each meal, and metformin, 1,000 milligrams BID. So if you take a quick look at this, she is taking 5 injections a day, taking pills twice a day, and testing her glucose 4 times a day. That's 11 separate steps to deal with her diabetes every day. And this was a working adult with a full-time job and family demands. So when talking to the educators, she voiced a lot of frustration about the fact that she was having to test 4 times a day, but her blood sugars were always high. So what's the difference? Why am I doing this? She was having difficulty because of her daily schedule, consistently eating when and what she should, and maintaining this complicated medication regimen. So next, we did our usual interventions. So the DSMT that she had, they did work on her diet a bit and exercise, and she did have some response. Her A1C decreased by 0.9%. But then our next intervention was to revamp her medication routine. We simplified it to BID because that's what she felt she could consistently maintain at breakfast and supper. Her basal insulin was combined into 1 dose at supper. Metformin was continued. We didn't go to the ER because she had a whole lot of these and wanted to use them up. So she stayed on the metformin as it was. And then her Humalog was discontinued. That was the most difficult part of her routine to maintain. And we resumed the sulfonylurea, the glipizide, 20 milligrams in the morning at breakfast time, and decreased her glucose testing with the elimination of the Humalog to BID at breakfast and supper. So if you analyze this, she is down to 6 steps a day from 11 steps a day to deal with her diabetes. And at her follow-up visit, 3 months later, she was much happier, comfortable with, and able to maintain this diabetes schedule and monitoring. So she hadn't really changed anything. Her A1C was now down to 7.7%, a drop of 2.7%. She'd actually lost a little weight. Often when you tighten control, you expect them to gain a little. She was using a home glucose meter. Her 4-week average home glucoses were now at 135, and she was actually starting to have some mild hypoglycemic episodes during the day. So our plan at that time was to just reduce her glargine insulin to 46 units, continue her oral meds as is, and nowadays we would put her on a CGM. And next, Dr. Stewart is going to share some suggestions on how to approach your patients about addressing their diabetes control.
Okay. Okay. Let me scroll down. Let's see. All right. Okay. All right. Thank you so much. So, Dr. Reddy had the high tech for monitoring. Dr. Leigh had the low tech and dealt with the important issue of adherence. This is no tech. So we have, as you've seen, the research has shown what works. But the reality is you've got the patient in front of you or in telemedicine, and it's working with the patient so that he or she could be on a regimen that would be beneficial. So here is an example. of a technique that has been shown for various patients to be helpful. A 60-year-old male with type 2 diabetes, hypertension, dyslipidemia. He's already on oral diabetes medications, hypertensive medication. He's taking a statin. His blood pressure is 160/90. His A1C is 10%. His LDL is 160. So all of us will be thinking, well, his diabetes, his blood pressure, and his lipids are not in good control. He's going to need more treatment. But he beats you to the punch. He complains that he's on too many pills. And he admits, like Dr. Lee saw, decreased adherence. And he certainly has avoided any injection medication. So he's got a need, and he's already expressing feeling really overwhelmed. So what can be done? Well, the patient negotiation technique. The opening words are to try and have him give the green light so you can discuss it. And you could say something such as, I'm concerned about your medical conditions. Would it be okay to discuss them with you in more detail? He may say no, which is better to know that sooner than later, and to say, okay, at some point in the future, when you're open to it, I'd be glad to discuss it. But most patients will talk about it because they sense that there's a need and you're there to help. So when you get the green light, you could say something to the effect of, people with diabetes, high blood pressure, cholesterol, out of control, are at higher risk for heart attack, stroke, and premature death. Pretty scary stuff to hear. But then you can add, when those problems are in good control, the risk for heart attack, stroke, and premature death go way down. All right? So then you can take out a piece of paper, and on one side, use the letter, the number 1, which will represent no change. And the other side represent 10. The patient will make every change advised. So in other words, it's sort of a third party. And it's trying really to take the shame, the guilt, the embarrassment out of it for the patient, because you just want to see, where is he? Where is he mentally? Because that could be a pathway to get him some help. So you've got a 1 to 10 scale. And you'd say, 1, when you walk out of this office or when we finish our telemedicine, you're not going to make any change. 10, you're going to do everything that's recommended. Where are you on this 1 to 10 scale? And at that point, you've got a dialogue. And he could say something like, I'm a 6. And at that point, you could say, okay, 6, why not a 3? And then you can get some insightful information. He would explain why he's not a 3. Maybe it's, he's got a child that's going to be graduating high school and he wants to be there. He knows a neighbor who had an amputation from diabetes. There could be some factor that is a motivator. And then you can say, okay, 6, why not a 9? And he could give you the reason. He could say, something, realistically, he's not going to make that many changes, or he's not the one who plans the meals at home, or he's got a busy work. There's something that will help get an idea, what is his life like that leads to his thought process. And with that, intervals, if he's 0 to 3, he's not ready to make a change. And you could say, consider in the future, when you're ready to make changes, I think you'll do a good job with them. Sort of let him mull it over, and something that can be expressed later. If it's 4 to 6, it looks like he's possibly ready to make changes, and you could apply this thinking. It looks like you're open to making changes, which is great. What step, let's say, what 1 step do you feel comfortable making? Sort of toe in the water, make changes. If he's a 7 to a 10, it looks like he's ready to make changes, and you can say, that's great, that you're ready to make changes for your health. We can help you on that pathway. Just to let you know, MAVEN project has many other diabetes presentations for continuing medical education. Here's a list. If you're interested in any, reach out to Kristen. She can help connect you with that. Here are the resources. Dr. Reddy talked about Tidepool and Freestyle Libre and Dexcom. If you want to look at the American Diabetes Guidelines, here they are. Here's telehealth program successful tips. Dr. Reddy talked about the distress screening tools. These are some things that'll be helpful. Patient education, there's the American Diabetes Association. There's Breakthrough Type 1 Diabetes. I used to be JDRF. They've got various information. And with that, why don't we go ahead and open it up to questions?
Thank you so much. Fantastic as always. I have a few questions in the chat, and I'm just going to put a quick reminder. If you could put the questions in the Q&A box, sometimes I lose them in the chat, and then I feel really bad that your question didn't get answered. But I think I have them all this time. First one, do you see us moving towards continuous glucose monitoring for everyone? It could be such a motivator.
Yeah. Great question. The EDA just published its new standards, and under that, they've obviously everybody on insulin. CGM is indicated as it improves glycemic outcomes and prevents hypoglycemia. They also now have a statement in there that for individuals with type 2 diabetes, consider using a CGM. So right now there's not coverage for everybody, but I would certainly recommend that everybody with type 2 wear a CGM at least once, kind of like that science experiment, so they can see how different foods, activity, life in general, sleep, stress affects their glucose levels. And you as a clinician just have more data to be able to know exactly what to do for them in terms of the medications.
Wonderful. How easy is it for a patient to obtain a CGM, like RE insurance coverage, access to treatment, personal cost, health education?
So the CGM coverage for insurance is usually for anybody who's on insulin or has hypoglycemia. There are many commercial insurances who will cover CGM for patients with type 2 who are not on insulin. If patients want to buy out of pocket, there is now CGMs over the counter called Stelo, which they can get over the counter. It's $89 for two. Which is an expense. And then if the clinics wanted to be able to purchase it for their indigent patients, there is a program through Abbott where they can get it for $25 for each sensor. So I would definitely look into that for your patients who have no insurance and can't afford. And again, take advantage of the My Freestyle program. If the patients have no insurance at all, they can at least get one of them. So again, all of these require a prescription. The one that does not require a prescription is Stelo, but it only goes from 70 to 240, so it would not be good for somebody on insulin.
Good to know. How is the CGM filament placed, given the wear is for 14 days? Is the patient charged with each change? Sorry, my knowledge is limited on CGM.
Oh, excellent questions. So when it's a personal CGM, there's really isn't a charge. The patient's, getting their own CGM through prescription, and they can actually self-start looking at the app. It's very simple. You just press, there's a little inserter, you just put it, press the button, and it's done. It's extremely simple to do. So whenever it's the patient's own CGM, there is no charge. Like I said, patients can self-start looking at the app, or you can help them in the clinic. On the other hand, if you were teaching them how to do the CGM, so let's say your patient got a CGM through the prescription, and they're a little hesitant about looking at an app or looking at instructions and wants you to teach them, there is a code you can use, the 95249, to bill for training the patient on their own CGM. The third category is if the clinic decides to buy what's called a sensor for the clinic. An example would be the Dexcom G6 Pro, which is about $59. In that situation, the clinic has purchased the CGM and is then putting it on the patient where they could wear it for 10 days. In that situation, the clinic can charge for inserting the CGM, and that code is called 95250. So again, the clinic can charge when they're actually inserting or training somebody, but if the patient is self-starting, there is no charge for it. And the patients can change their own every 10 to 15 days, to 14 days, depending on which sensor they're using.
All right. Just remember to use that Q&A box. Okay. Any long-term concerns with TZDs, as in oncogenic, even if they don't have the bladder cancer history?
Okay, interesting point. So when giving a medicine, in the back of our minds, it's always helpful, for me at least, to admit that we don't know everything about anything. We're always learning new details. But medicines like pioglitazone have been around for decades, and they're well beyond investigational, and we know quite a bit about it. And so right now, the only malignancy that's been associated is bladder cancer. So if you have a patient with bladder cancer history, don't use it. But there's no indication for the other cancers, particularly the more common ones. So with the data we have at this point, it would be fine to go ahead and do.
Even without insulin, considering how many pre-diabetics are out there on their way to DM, using a CGM can affect behavior modification that can result huge benefits in prevention of progression, hopefully. Oh, it was just a statement. And then we have Dr. Shamakani. I'm going to unmute you. Feel free to unmute yourself and ask your question.
I feel like I'm on a mission at this point. I mean, a bit of a personal thing. I just stuck one of these things on myself less than 24 hours ago. And I am already rabid. So just being that I just found out I was pre-diabetic myself because with no family history. I have a BMI of 22 and out of nowhere. So I'm watching that thing and absolutely lost my mind. I had a few taro chips and it went up to 170 and I was almost screaming and running around the house in circles and doing squats for about 10 minutes. So, I mean, I can see how it can really affect behavior modification. And Dr. Sadur, you mentioned 48% of the adult population will have prediabetes of some of the at one of your lectures, one of your sessions, you mentioned that. And I'm thinking, this is the chunk where we have to do the prevention instead of waiting for people to get to a point of decrepitude where we're trying to bring them back from the edge. Why not prevent? And this is such a small price to pay. You know, if people, if you can see the change right there in front of you, it's huge. And why wouldn't the ADA recommend it?
You know, if I could just chime in there, you're absolutely right. We know that everybody's gut microbiome is different and everybody responds differently to different foods. So when you wear that CGM, you know how your gut is responding to different foods in terms of glucose levels. But I wanted to let you know that there is hope. We have a grant. We are doing a randomized controlled trial looking at exactly what you said. It's going to be in the YMCA. It's a healthy lifestyles program where one group will get CGM and the other group will not. So we'll actually have clinical evidence to say how the CGM benefits. So
Thank you.
tuned. Yes, the study is starting in January. So
Okay. Thank you.
You know how I feel about a good YMCA program. I always appreciate the YMCA had the diabetes prevention. Okay. I don't see any more questions, but we'll pause. Any last minute questions, please feel free to get them in. Oh, here we go. Hi, Dr. Hussein. If people would do what Dr. Lee said, nutrition and lifestyle modification will prevent the progression of prediabetes and DM. And we just seem to have a lot of MAVEN Project volunteers, so thank you all for joining us today. Dr. Hussein, question: how can we get enrolled in this study?
Oh, I'm sorry. This study is actually at the YMCA in Port Huron. So you'd have to live in Port Huron, Michigan in this area to be enrolled. So that's where the study is being. So, hey, we'd love to see you in Michigan. Our area is wonderful. So please come over.
That's funny. All right. I don't see any more questions. So just a reminder that you can, your CME survey is going to appear in a tab on your internet browser when you close out of this webinar. It's going to look a little weird. Click on it and complete that. We appreciate all and every feedback. The volunteers do get to see it, so good and bad. And also that's how you get CME credit. So thank you. Oh, there we go. What continuity of care to your advocate in regard to ongoing assessment and care for patients started on CGM?
Oh, so if you start somebody on CGM, so it really depends. If they're on insulin, you want to continue them on CGM. If they're not on insulin, what we did at Carbon Diabetes Care is we usually kind of did like a boot camp approach and had them wear CGM for that first 6 to 8 weeks till they got to goal. And then we did shared decision making at that point. If the patient was not on insulin, not on an agent that caused hypoglycemia, they could choose to either continue on it or not continue on it. So that's kind of the approach we took. Again, shared decision making between you and the patient based on what you feel is best for the patient and what the patient would like to do.
Wonderful. All right. Well, thank you all for joining us today. And Dr. Sadur, Dr. Reddy, and Dr. Leigh, as always, fantastic. Thank you for doing this.